We would like to welcome you to our annual CDC Federal Office of Rural Health Policy webinar. This year, we'll be discussing NHSN AU Option, using data for action in critical access hospitals. My name is Melinda Newhouser, and I am the pharmacist and acute care lead for CDC's Office of Antibiotic Stewardship, and I'll be the moderator today. Next slide. After a joint welcome by CDC and the Federal Office of Rural Health Policy, a brief overview of CMS Interoperability Program and AUR will be presented by Amy Webb. And then Libby Dodds-Ashley will be leading an interactive panel discussion on using NHSN AU option data for action in critical access hospitals with Kiri-Ann Bennett and Mark Meyer. Each speaker will more formally introduce themselves at the start of their presentation. Next slide. Once again, we would like to welcome you to our annual Antibiotic Stewardship webinar in celebration of US Antibiotic Awareness Week and National Rural Health Day. We are grateful for the antibiotic stewardship activities that you and the audience lead and support the entire year. We hope that you have an impactful US Antibiotic Awareness Week for your hospital and healthcare system. I am thrilled to introduce Dr. Kristen Dillon, the Chief Medical Officer at HRSA's Federal Office of Rural Health Policy, to welcome you and provide opening remarks.
Hi, good afternoon. Thank you, Melinda and CDC colleagues. I'm grateful to all of you in the audience today too. Thank you for using your time today to show your commitment to provide high quality care, especially for Americans living in rural communities. So my name is Krista Dillon. I serve as the Chief Medical Officer of the Federal Office of Rural Health Policy, a role that I assumed earlier this year. I'm trained as a family physician. I have about 25 years experience working in rural communities in California, Colorado, and currently Oregon, including a number of critical access hospitals. So across my clinical, administrative, and policy roles, I've been a really strong advocate for rural communities, including for their ability to access culturally responsive, affordable, high-quality healthcare. And that's what we're here about today. So thanks. It's great to be part of this webinar as we observe National Rural Health Day tomorrow, leading to what we sometimes call National Rural Health Day Week. So improving antibiotic use in hospitals is really key to improving patient outcomes, decreasing antibiotic resistance, and also reducing healthcare costs. According to the CDC, 20 to 50% of all antibiotics prescribed in US acute care hospitals are either unnecessary or perhaps inappropriate, which leads to avoidable harm, including adverse drug reactions, C. difficile infections. Overexposure to antibiotics also contributes to antibiotic resistance, making antibiotics less effective for the patients involved and for all of us. So in 2014, the CDC released these core elements of hospital antibiotic stewardship programs. It identifies key structural and functional aspects of effective programs and elements designed to be flexible enough to be feasible in hospitals of any size. While lower volume hospitals might not have the patient counts that allow calculation of some of the more specific hospital-acquired conditions metrics because of the difficulty of having the standard infection ratio be meaningful, this measure, the core elements measure, is about structures and processes. So it ensures that any hospital of any size can check that they're taking the important steps to make their facilities safer. We'll also see today in the case studies presented that smaller hospitals may be more likely to see initially concerning results in some of your statistics just due to low overall volumes and sometimes more noise than signal. This does not impact the usefulness of your work. As with any quality improvement activity, the data is the launching pad for the quality improvement work, not the work itself. So today we'll hear about real-life examples of how antibiotic stewards put on their Sherlock Holmes hats and went looking at the real world to understand their data and inform change where needed. The Federal Office of Rural Health Policy has appreciated the ongoing partnership with our CDC colleagues around these efforts and their continued focus on making sure small rural hospitals have relevant resources. So with that, I'm thrilled to hand things off to my colleague at the CDC, Amy Webb.
Hi, thank you so much. Next slide, please. So my name is Amy Webb. I am a public health analyst on the NHSN Antimicrobial Use and Resistance team. And today I'm going to be talking to you about the CMS Promoting Interoperability Program, which I'll abbreviate as the PI program, and Antimicrobial Use and Resistance Module reporting into NHSN. Next slide, please. So one of the very common questions and confusions we get often is, since the PI program is a little bit newer to some of the folks that use NHSN, specifically also pharmacists as well, it's different from and separate from the CMS PI program, the CMS program that's used to submit your HAI data. So your CLABSI and your CAUDI lab ID events, that is a separate program from the PI program. So I've included a link, the link as well as the screenshot here on the slide of PI program measures. And just to kind of highlight what data are collected in the PI program versus what you're probably much more familiar with for the HAI measures. It's important to remember that most acute care hospitals participate in the PI program, and critical access hospitals are eligible to participate. So don't just think that because you're critical access, you might be excluded from this program. There's a very good chance that you do participate. If you're unsure whether or not you participate in the program, please reach out to your quality reporting folks and or someone in the C-suite. There is money associated with participating in this program. So someone in your facility knows whether or not you get the money for participating in this program from CMS. Next slide, please. So starting next calendar year, if you weren't yet aware, the AUR module measure will become required under the public health and clinical data exchange objective of the PI program. So this measure, again, applies to all facilities that participate in the program, which includes hospitals and critical access hospitals. And it's important to note that the measure includes submission of both AU and AR data into NHSN. So for next calendar year in 2024, facilities must be able to attest to either being in active engagement with NHSN to submit their AUR data or claim an applicable exclusion. So let's dig into that a little bit more on the next slide. There are two ways to be in active engagement with NHSN, and this option 1, option 2 language is the same across all the PI program measures. So option 1 is considered pre-production and validation. So that consists of completing a registration of intent to submit AUR data screen within NHSN. That's a very simple one-time screen to be completed. Then the second part of the option 1 is to send us test files for validation. So you'd work with your vendor to create these test files, ideally containing test data, to send to us for validation. Now you could stop there for calendar year 2024. You've registered and you sent us your test files, and stop and still get your full credit for being in active engagement with us for 2024. Or if you're ahead of the game, you can move to option 2, which is kind of the next step up, validated data production. So that includes registration within NHSN. So that's a required step, whether you do option 1 or option 2, you have to register. And then submit production AU and AR data to NHSN for calendar year 2024. That is specifically 180 continuous days of AUR data submission. So a note about that 180 days, you're going to hear me refer to it in the next few slides. It's named by CMS as the EHR reporting period. So those 180 days are the same 180 days for all of your PI program measures for your facility. So if you're submitting your production data next year, you are going to submit your AUR data for the exact same 180 days as all of your other PI program measures. So perhaps it's the first 180 days of the calendar year, maybe it's the last 180 days of the calendar year. but whomever does your quality reporting to CMS hopefully should know what your EHR reporting period or your 180-day is. And a quick note as reference on the bottom of the slide. So let's say you just do option 1 for next year. You register and you do your test files. That means that for 2025, you have to move to option 2, validated data production. So CMS put that in their rule last year, perhaps, that facilities can only spend 1 year in option 1 starting next year. Next slide, please. So we have 3 exclusions for the RAUR measure currently, so we'll walk through those. Number 1, does not have any patients in any patient care location for which data are collected during your 180-day EHR reporting period. So that probably doesn't apply to most facilities. Perhaps if the facility was closed due to natural disaster or complete construction or something like that, then you would meet the exclusion criteria for number 1. Number 2, does not have the electronic medication administration record or barcoded medication administration records, the EMAR or the BCMA system, or the electronic ADT system during your EHR reporting period. You would get the exclusion. And number 3 relates mainly to the AR side of things, does not have electronic laboratory information or LIS or the electronic ADT system. And I do want to point out that exclusions are decided upon by CMS. So we at NHSN can help you determine whether or not your specific scenario may meet an exclusion, but ultimately CMS is the one that is the group that will need to say yes or no whether or not your specific scenario meets an exclusion criteria. Next slide, please. And a few notes on our exclusions. So I've already covered this first bullet. The sub-bullet to number 1, exclusions are submitted at the same time as your PI program attestations. So the attestations are submitted by the last day in February for each year. So let's say today that you are going to meet an exclusion, maybe you cannot submit that exclusion until February of 2025, because that's when you'll be submitting attestations or exclusions to the calendar year 2024 measures. So kind of keep that in mind as you're thinking about this. Hospitals claim an exclusion to AU or AR would claim an exclusion on the measure as a whole. So a lot of facilities will likely meet the exclusion for the AR data, because especially if you are sending out your isolates and those susceptibility results come back to you via PDF or fax that are then scanned into the patient record or attached as a file to the patient record, those data are not coming back to you in a form that's interoperable, and those data cannot be pulled by your vendor system in a way that can be sent to NHSN. So essentially, you would meet the exclusion criteria for the AR data. So if that's the case for you, you do claim the exclusion for the measure as a whole, for AUR as a whole. However, we would encourage you, if you have AU data, if it's up and running, for example, or if you're going to get that up and running first, go ahead and submit those data to NHSN, even though they might not be required per the CMS PI program. And lastly, if your facility does not have access to all results for each eligible organism as outlined in the protocol, then you would claim an exclusion. Next slide, please. So as we've already kind of mentioned, the measure is attestation based. So it's a yes or a no in the CMS HQR system. We do not provide any AUR data to CMS for your measure, for this measure, and no AUR data will be posted publicly anywhere on CMS Care Compare specifically. The goal of the PI program is really to increase interoperable healthcare data exchange. So you'll do all of your attestations or your requesting for exclusions within the HQR CMS system. So we only provide you as a facility's documentation to use as proof in the event that CMS were to audit you. Next slide, please. So a quick note about some reporting deadlines. So let's say you're going to go with option 1, pre-production and validation. So per CMS measure specifications, you're supposed to complete that registration of intent within NHSN within 60 days of the start of your 180-day reporting period. So ideally, you would make sure that you have your test files or your production test files ready or almost ready prior to registering in NHSN. That's because after registering, we will immediately send you a request for test files. So that's an automated request that is sent out after registering. And facilities are supposed to respond to our requests within 30 days of us sending it to you. Failure to respond twice within your 180-day EHR reporting period would result in your facility not meeting the AUR measure because it's assumed that you're not in active engagement to send us what we need. So for facilities that are going this route, option 1, we ask that you do that registration within 60 days of your reporting period, but ideally, please submit your test files to us no later than November 1st of 2024. That just allows us our team enough time to review, process those files, and send you back a letter that says, congratulations, your test files have passed. So this November 1st, 2024 is kind of our internal NHSN deadline, where if you have your test files before that, by all means, please send them to us. But that November 1st should be a goal for you to get us your test files so that we can get you back the documentation that you can use as proof. Next slide, please. So no worries if you've registered too early. So some facilities completed that registration many years ago, perhaps on accident, maybe on purpose. But regardless of that, if you've registered but you don't yet have those test files ready, that's okay. You can just send us an emailed status update that just says what you've been working on. And these general status emails can just be used as proof if CMS should audit you to show that you are actively engaged, you're actively working towards getting those test files ready. Next slide, please. So let's say you are going with option 2, the validated data production. So again, per the CMS program specifications, facilities should report their data on an ongoing basis during their 180-day reporting period. We at NHSN will automatically send out status letters on the first day of every month. And a final annual status letter is sent out on February 1st, showing the previous year's submission. So that means for your 2024 annual status letter, you'll need to make sure you have all of your relevant AUR data submitted to NHSN no later than January 31st of 2025, since that 2024 report is going to be generated and emailed to you at 12:01 on February 1st of 2025. And I have a screenshot on the slide here that just shows what that report looks like. It's very high level, just with a yes or a no by month and file type. Next slide, please. So I didn't have a whole lot of time today to cover all the great details of the PI program and AUR reporting, but we do have an office hours session that I wanted to share with you coming up in a few weeks after Thanksgiving. So this session will be on Tuesday, December 5th from noon to 1 Eastern time. We'll be sending out the slides so you can get access to that registration link, but this office hours session is a short presentation given by me, and then the vast majority of time is us just going through the Q&A and answering all the questions that you may have. So next slide, please. And then wanted to highlight some of these resources so you have them available. Again, you'll get the PDF of the slides tomorrow, hopefully, and you'll be able to click on all these links, but we have a lot of great resources available for you. Like I mentioned, there was just not enough time today, but feel free to check out our AUR trainings if you need more information about what type of data are reported. And our NHSN CMS requirements page contains a lot of great FAQs that I'd highly recommend reviewing. Next slide, please. So with that, I'm going to turn it over to my colleague, Libby, for the next portion of our presentation. Thank you.
Thank you, Amy, and hello, everyone. Happy Antibiotic Awareness Week for 2023. My name is Libby Dodds-Ashley. I am a stewardship pharmacist based in North Carolina at Duke University, where I work in the Duke Antimicrobial Stewardship Outreach Network. And I'll tell you a little bit more about that in a moment. But I'm here with two colleagues, Carrie Ann Bennett and Mark Meyer, who are both active stewards in critical access hospitals. And so we thought that we would start today by giving some brief introductions. And so first I'm going to let Carrie Ann introduce herself a little bit more, as well as her hospital and her stewardship program. Carrie Ann?
Hello, thank you for having me here today. So I am an antimicrobial stewardship pharmacist at Gritman Medical Center. Next slide, please. And Gritman Medical Center is a patient-centered nonprofit critical access hospital. We are located in Moscow, Idaho. So we're right on the border of Idaho and Washington. We serve two universities, the University of Idaho and Washington State University. We also serve over 40,000 residents of rural Latah County. We have 6 regional primary care clinics, and we also offer numerous specialties. So it's kind of normal that we have so much for a critical access hospital. We offer oncology, urology, wound care, and orthopedics. Next slide, please. So our antimicrobial stewardship program began in 2016. The director at that time created the charter, and then in 2018, she asked me to become the lead pharmacist on the team. During that year, I joined the University of Washington Antimicrobial Stewardship Program. Now it's called the Center for Stewardship in Medicine, and that has been extremely helpful in our program. It has been a very long path for us to be able to submit our antimicrobial use data to the NHSN. We ran into numerous issues with our electronic health record, and we ended up going with an outside vendor to submit our data. And I began that process in 2021. So we started submitting our antimicrobial use data and resistance data in January of 2023. And actually it was more in the antimicrobial resistance data in January, but the use data, I was able to start that in the fall. And then I backdated all of that from April 2022. Next slide, please. So my colleague, Mark, is going to introduce himself and his health system.
Thanks, Carrie Ann. Like she described there, we are a health system that is based out of a critical access hospital in rural Colorado. And you can see we've had a new building since 2018, some pictures there. There's a slide of my office window in the wintertime, which is such a hard place to work sometimes. And the map I wanted to show you kind of shows you the rural of this area is that we're right in the center of the map in the Four Corners area. So it is literally 8 hours to anywhere. And one of the fun things that my CEO noted to me the other day was the fact that we are 4 to 6 hours away from an interstate system, any direction that you go. So it is truly rural. There. Next slide, please. So it's pharmacist-led antimicrobial stewardship program. I am the director of pharmacy and a director of infection prevention. I've run the program since we started uploading data in 2015 to NHSN. We serve about 62,000 people in the Four Corners area. That includes Utah, Arizona, New Mexico, including Ute Mountain Ute Reservation and Navajo Reservation. We have 20 inpatient beds, and we have two clinics on campus. We are supported by a clinical pharmacy infection prevention software, and our RS team is heavily involved with ASP program. We do provide outpatient services with a busy ED, walk-in clinic, most of the things that Carrie Ann described, orthopedics. That we also have a very busy outpatient pharmacy in our clinic that fills upwards of 450 scripts a day. And the clinics have over 12,000 patients, and the pharmacy has over 15,000 patients. We do have stewardship in our clinics, but the work there is manual. It's a heavy lift with no software support. We are currently looking for some sort of ASP software support in our clinic because we do know that it's very needed in that area. Next slide, please. And I'm going to turn it back to Libby.
Thank you both. I thought I'd also share a little bit about my practice before we get into the topic for today. I mentioned that I work in the Duke Antimicrobial Stewardship Outreach Network, which we call DASON. We are a network of 38 community-based hospitals that are throughout 4 states in the Southeast. And we actually highlighted in yellow on this slide are our 2 critical access hospitals that are current members, with actually another hospital looking to join. So we do have experience in hospitals of varying sizes. The average bed size of a DASON hospital is around 150 beds. And I think it's important to note that while we have a great team of colleagues who do inpatient stewardship at Duke Hospital, we run this a little bit different in how we do the program for stewardship in our community hospitals. Next slide, please. And we serve as liaisons where I have a team of myself plus 4 pharmacists, and we visit these hospitals on average once a month to help with their programmatic stewardship needs. We have a data-driven approach to stewardship and have worked with data a long time. So similar to Mark, we began reporting data for our facilities into NHSN AU in 2016 and have been able to submit data back to 2014 in some cases. So we have a long history of using this, and all of our DASON member hospitals actively report AU, and most of them will be up on AR by the end of the calendar year. So we're excited to report. So we also have some experience with our AUR reporting. And now that you have a little bit of an idea about us and our practices and where we are working as stewards, let's go ahead and on the next slide, set the stage for today. We know that many of you are excited and probably a little bit preoccupied with getting your data into NHSN right now, or maybe you've newly gotten your data in and you're wondering what next steps are to do. So what we thought we would do is come and bring you real world case examples. You are literally going to hear from the trenches today about how we use these data in our practices to change antibiotic prescribing practices, to modify provider behavior, and also just to better inform our stewardship programs. And we'll talk a little bit more about some resources that are available to you, similar to what we do as we go through this. Now, when we were planning for the presentation today, we all talked about examples of where we had high use or low use or what to do with early findings. And Carrie Ann, I was wondering, could you share with me an example where you were able to particularly implement the NHSN data to help improve your stewardship program?
Yes, I will gladly do so. So the example I'm going to use today is using gram-positive infection antibiotics. So primarily antibiotics used to treat MRSA. Next slide, please. So the NHSN classifies certain antibiotics that they are looking at. So these antibiotics that are used to treat resistant gram-positive infections are listed below. And then the antibiotics that are starred are antibiotics that we have at Brittman Medical Center. So that includes daptomycin, linezolid, occasionally we use ritonavir and vancomycin. Next slide, please. So here is a report directly from the NHSN about our facility. So this is facility-wide data right here, and it has the different classes of antibiotics. And you see that gram-positive one, that's the one I will be focusing on today. And so our SAR was above 1 for that. That was 1.219. And so I was looking to see a SAR of 1 or less. And so I took a look at that, and that's the example I'll provide today. Next slide, please. So here's another way to look at it. This is where the data is divided by location. So CCU is our critical care unit, and MSU is our medical surgical unit. So on our MSU unit, the SAR was 1.168, and on our critical care unit, the SAR was 1.397. Now, I should mention this data is for data from April 2022 to March of 2023. Next slide, please. And then I took another report within NHSN that is showing the SAR for each month. And this is the same antibiotics used to treat resistant gram-negative infections. So I'll interchange with MRSA antibiotics, essentially. So starting of July of 2022, I noticed that the SAR was increasing, and it peaked in November of 2022 with a SAR of 2.107. Next slide, please. So this is our CCU data. I should mention this slide before was our MSU data. Now our critical care unit, it's kind of all over the place. There's sometimes we may not have patients in our critical care unit for long stretches of time, And there might be times where we have 3 or 4 patients at once. So you can see the SAR varies. In April of 2022 is 3.825, which is quite high. And then you see it goes all the way down to 0.382. So that one I wasn't looking at as much as the medical surgical unit. Next slide, please. So another way to look at the data. So for me, this is more visual and more helpful to me. This is a plot graph that is available in NHSN. And this is our medical surgical unit. And so you can see where that trend is happening of the SAR increasing, starting in about July, and then goes up until November. And just to note, the antibiotics that were the top 3 used were vancomycin, linezolid, and daptomycin on the medical surgical unit. Next slide, please. And then this is just comparison. This is our critical care unit data. And as you see, as I mentioned before, it's kind of all over the place. Kind of depends what was happening. And interestingly, the top 3 antibiotics used were linezolid, vancomycin, and daptomycin. So linezolid was actually used over vancomycin. Next slide, please. So what was going on? I had to dig deeper into our data at our hospital. So this report is from our outside vendor. This is not within NHSN, but I can run reports and see who is prescribing what and during what time frame. So each bar represents a different hospitalist. And I looked from August of 2022 to November of 2022 and kind of reviewed who was prescribing what. And this is just solely for vancomycin. Now that light gray bar, that was our new hospitalist that started in August. So you can see prescribing really kind of shot up there in September and kind of evened out after that. Next slide, please. So this is compiled data of vancomycin, linezolid, and daptomycin, and that's from August to November of 2022. So this is all of them. I continue to dig deeper into the data, and I can actually go within these graphs and look up individual prescribing in individual cases. So interestingly, that dark gray bar right there is my antimicrobial stewardship physician. And so when I looked into that data, that was all from one patient. That was a patient who had osteomyelitis, and they were being treated with daptomycin, and then they were switched over to linezolid. And they actually ended up being at our hospital for 6 weeks. So the NHSN is great to see trends and to see where you're going, but then you have to dig into your own data to see what was going on. Now I will hand it back to Libby.
Thank you so much, Carrie Ann. That was a great example of how the NHSN data and the reports that are available to you can help you identify and refine some of the places you want to investigate further for stewardship work at your hospital. I think there are some important things I want to point out here. First of all, Carrie Ann showed very nice use of some of the newer functionality within NHSN analytics, and those are the targeted assessment for antimicrobial stewardship, or TAS reports, that allow you to quickly rank your overall SARs for your hospital based on drug category, and then quickly drill down to which areas those SARs might be especially high, and also which agents within each SAR category are driving the SAR. Now, some of you out there, I bet, are pausing and saying, wow, that was a lot of data to take in. And I'm wondering how I'm going to quickly get up to speed and be able to analyze my data and look at my SAR data and inform my stewardship work. Well, I have good news. On the next slide, part of the reason I'm here today is that I have been working for the past a little bit over a year with the CDC on a project of how to use the NHSN data to implement, inform, and assess your antibiotic stewardship data and stewardship work using the NHSN metrics. What you see here is a screenshot of our web-based interactive tool that shows you how to use NHSN AU and AR data in really, we've tried to make it as practical as possible. So this is a case-based program where you can actually identify different problems with your SARs, and then you get walked through examples of how to use the data. We also have some additional metric guides, and I'll show you what those are in just a minute. Next slide, please. So to use Carrie Ann's example, in this case, you could go into our clinical case scenarios and identify that you have a high individual SAR category. And then we go into somewhat detail of a mock scenario. And when I say mock, I will say that we had a large project team of stewards from the University of North Carolina, my colleagues on the inpatient hospital team at Duke, as well as the DASON steward liaisons. And these were all taken from real world examples of how we apply the NHSN data to stewardship in our network of hospitals. So we go into the details, we talk about what the issue might be, and then we walk through step by step how to look at and how to use all these various reports. Anytime that we identify an NHSN analytic tool that we use, it is very clearly outlined there, including any modifications we make to the standard package that's available when you open NHSN. It is our hope that you should be easily able to take these clinical scenarios and apply them to how you do your stewardship analytics. In addition, for every scenario, we provide some potential interventions, although I'm sure many of you will also have creative solutions to this. Next slide, please. So this is an example that shows how you can also do some augmented data. So maybe you don't have a vendor like Carrie Ann has that can quickly give you prescriber-based data for who is writing for various prescriptions. We have actually made user guides for those metrics that I mentioned, and we've tried again to make these fairly simple. Every metric guide has a downloadable PDF with step-by-step instructions on how you can acquire the data. If there are some data elements that you need to ask for from your IT resources, there is typically a Excel template so that you can provide that to your analysts. And then we also have created videos to help take you step by step. And so we do have an example actually for prescriber-specific prescribing rates for antibiotics, just like Carrie Ann showed from her software package that's there to guide you. And on the next slide, perhaps the most creative name, I don't think I necessarily came up with it. We call this StewTube, because anytime that we sat down for the past 4 or 5 years and tried to create a new way to look at our data, we were going onto YouTube and trying to figure out how to do that in a simple program like Excel. So we've actually created antibiotic stewardship specific videos that go through the examples and walk you through our step-by-step guides. You can see exactly where we click. You can see exactly what the data look like. And those are all available to you as well. So we have a variety of metrics, and we have those 15 case scenarios as part of this project. And we also have templated PowerPoint presentations if you are just about to take your stewardship data out of NHSN AU and start presenting it either to prescribers or to administrators at your facility. We have some tips and tricks on how to do that best as well. But I know that, whenever we start looking at our data, often that category of agents predominantly used for resistant gram-positive infections comes up on top of the list as a high use category. Mark, do you have any experience there that you want to share with your NHSN data in that category? Mark, you're still on mute.
Great. Yep. Thanks, Libby. We'll go on to the next slide. So I usually, when I first started in 2015 into NHSN, I would pull, that monthly data, and it was bouncing around a lot. So I tend to average my data now during the time frame I'm looking at. So this is just taking those SAR values that you have in NHSN and average them. And this gives me a nice graph, and I know my problem areas and what's going on. So in this slide, my problem area is narrow spectrum beta lactams, if it is a problem. And you see my gram positives during 2023 were actually fairly low at 0.6. Next slide, please. But going back to 2020, we looked at monthly data in NHSN. I got this picture, and you've seen this trend line of it going down since January of 2020, clear down to December of last year. You see a gradual trend line, but you see all these vancomycin or gram-positive SARS that were really high, upwards of 2 in many months, especially in 2020. So that was a concern, obviously, of ours, and so we started working on that, really looking at things. We audited all of our patients during that time period. Next slide, please. And so where did we get from those high SARS of 2 down to that 0.55 or 0.6 that you saw a little bit ago? Well, having identified vancomycin usage as the potential area of improvement to the high SAR, we pulled data, and I have pharmacy students from the University of Colorado almost all the time, and we analyzed quarters of 2020, really looking for stewardship endpoints of, did we de-escalate, were the sensitivities correct, and was the diagnosis warranted? And what we saw was about 30% of the time, we didn't need to use vancomycin at all on those patients, and they weren't being de-escalated appropriately. So what we really started doing is on daily rounds, when we round with the hospitalists in our building, our pharmacists have been starting to really talk to our nursing staff and talk to the hospitalists and all the students that have come in since then. We really talk about vancomycin usage every day, and we really look at those vancomycin orders really heavily. And so you see that all started to go down, and over time, but it did take almost 2 years for us to get vancomycin usage back down. I think also there were some guidelines coming out at that time that were kind of confusing for providers that said you should put everybody on vancomycin and such, and I think that also contributed to that problem. Next slide, please.
Yeah, Mark, this slide it intrigued me because I know we wanted to talk about, and you have such a great example with those agents traditionally used for pathogens like MRSA, but it did speak to me that you had these high SARs for beta-lactams. And do you want to speak to that a little bit and why that was or wasn't a target, and how the data actually helped you reinforce some?
Oh, yeah, absolutely. So you see this, and in fact, it might have been you and Melissa Johnson that when we were at a conference 2 years ago that I kind of discussed this and got some data from you. But beta-lactams are something that we want to utilize in stewardship because these are the narrow spectrum products. So let's talk about that. Next slide, please. So one of my favorite reports is the TASH dashboard in NHSN because I can set the values at 1 and I can go through the next 4 quarters and see, the areas that I might be elevated in. And you can see on this TASH report, the narrow spectrum beta-lactams are elevated in all 4 quarters. And and that's also telling you how many days of therapy you need to reduce to get to 1, if you want to look at it that way. So next slide, please. But what it also tells you is if you scroll on down after you run this report, is the exact antibiotics that are causing these days of therapy to be elevated. And you see it's cefazolin, ampicillin, suboxone, amoxicillin, augmentin. It's the things that on my med surg unit that I want to be de-escalating and using through that. And so that was data that I wanted to hear. And again, we audited these patients just to make sure that we should be using cefazolin and ampicillin and cefadroxil, things like that in our formulary. We wanted to be sure before we could pronounce that this high SAR was something that we wanted to see. And so we did that. We didn't find any issues. And in fact, in our area, being the rural area I described, we're very antibiotic naive. We don't need a lot of broad spectrum antibiotics right now to treat our patients. Most of our resistant infections come back from a tertiary center in one of the cities somewhere. So next slide, please. And Melissa Johnson at Duke, actually, this is her slide that she allowed me to use. I've been using it for a couple of years now, but it showed that Laborsi et al. In 2021 really looked at what's the impact of having some kind of ID specialist or some kind of antibiotic steward on a hospital system. And you can see here total antibiotic use when there's ID specialists of some kind on board, they had less antibiotics being used than there was none. And if you looked at narrow spectrum beta-lactam agents specifically, they were elevated. Their use was elevated over regular antibiotics classes, or even just in the beta-lactams. So you see that the impact of steward was to have more narrow spectrum beta-lactams being used. So next slide. And so doing that, it really allowed us to say, hey, we're going to live with that SAR as it is.
Yeah, thanks, Mark. I think it's so important to highlight that sometimes, our SARs might be high intentionally, and so we might be happy. I do want to bring up something I know is also at the forefront of many stewards' minds, especially if depending on who your accreditation agency is, because we are now being asked as part of our stewardship programs to track our ASP interventions. And I just wanted to go quickly, Carrie, is there any way that you've been able to do that using the NHSN AU data? Do you have any examples of that?
Yes, I do. Next slide, please. So here are some different graphs you can access within NHSN. And one of my stewardship initiatives is to monitor the use of fluoroquinolones. I want to make sure they are being used sparingly and appropriately when they are used. So kind of also following on what Mark was saying with narrow spectrum beta-lactams, you can see our highest class of used antibiotic here with this bar graph is cephalosporins. And then you see our fluoroquinolone use is fairly low. And then looking at this pie chart over here, that green right there, that is also cephalosporins. So I am happy to see that. And our top used cephalosporins are cefazolin, which makes sense, used preoperatively for surgeries, ceftriaxone, which I'd rather be using that over, say, like meropenem. And then vancomycin was another one I saw, not in the cephalosporin class, but another antibiotic that I saw was one of our top 3 overall.
That's great. Thank you. It's nice to have the data just right at your fingertips. If we go to the next slide, I'll also highlight our project and our toolkit, our interactive users guide. We also have examples of how you can pull the data down from NHSN and really see granular raw data. I think something that people sometimes forget is all the data that you put into NHSN, especially if you're someone who uses a vendor or maybe you're not in the day-to-day business of doing their reporting, you actually can extract that all right out of NHSN and see it for individual drugs. As both Mark and Carrie Ann have talked about, you are not limited to just the drug categories that NHSN describes. You have infinite ways on how you can customize the various reports and output. Next slide, please. And then I will say, in the example, one of our cases, as I showed, was IV to PO and how to track that program. You also have potential stewardship interventions that talk about other places that you can go look. One, make sure, are you following your IV to PO policy, et cetera, which is all really important. So you hopefully have learned through the course of time with us that we have lots of available options for how we can use the NHSN data. There are the reports right within NHSN, and there are sometimes some simple manipulations that you can do to those data to answer some further questions. Before we close up, I just want to throw 2 questions out to Mark and Carrie that I think are very relevant and sort of came up during the presentation today. The first one is, I know, Carrie Ann, you mentioned a SAR goal of 1 when you initially saw your SARs for the anti-MRSA agents. And Mark, you also on the task report put in a 1. How do you all set your SAR goals? What would you advise a steward on how to do that?
I think initially I would set them at 1, especially if you're new to the data. And then you might have them lower or higher depending on what you're seeing over time. I would do that, but I would work with them generally, unless you have an instance like where I did, probably 1 is a good starting point for that.
Just to say, yeah, 1 is kind of your benchmark. That's your comparative to what they have in the SAR data from 2017. And like Mark said, kind of depends on the class of antibiotics. Sometimes a high SAR is great to have, such as the narrow spectrum beta-lactams. You want to see more of that used. Another category is broad spectrum healthcare onset antibiotics. So those are things like meropenem, Zosyn, all your carbapenems. That would be another SAR that I would be tracking and hoping that would be less than 1.
I'd also add, if you are a small hospital, critical access hospital, and you do a lot of oncology and see a lot of those patients, you might have an elevated SAR that would be considered normal. So really look at your data. I think that's the key. Whether it's 1 or how you're setting, you got to take that. If it's above it or below it, you still have to look at the data and really make sure that that's correct, because you could be underutilizing also.
Yes, and we'll have the next slide, please. And I think that is important, Mark, to always be thoughtful of how you're using the data. I've given a lot of talks about how to use antimicrobial use data And I often get one question where people say, I've been submitting my data into NHSN for years now, and it's not changing. You know, the data are the tool to help drive us to smart stewardship interventions, but we have a lot of job security, and we still need to sort of explore the reasons that use might be high. I also noticed a trend, and just to highlight to everyone, so that everyone is aware in the analytics, you know, certainly you can get SARS out in monthly increments, which can be helpful, but especially at smaller hospitals, it might bump around a lot, just like you saw, Carrie, and one patient can greatly, we see that in our critical access hospitals all the time, like, oh my goodness, it was SARS 2, and it was 2 patients transferred in on a single antibiotic or antibiotics from the same grouping. And so something that we've started doing is going to, at most, a quarterly report, which helps us sort of even out that data. Mark, you did that yourself, I think, by even by averaging some of those together over a longer period. So that's also available right in the NHSN platform. And it's an easy modification. We have instructions how to do that in the user's guide that Amy mentioned at the start of the call. So we do want to leave lots of time to see your questions. I see we have questions coming in, but in summary, for just to close out our panel discussion for now, is there are lots of ways that the data you have through your NHSN reporting can help you implement stewardship interventions, inform that work to be smart so that you're not looking or barking up the wrong tree, as we tend to say, and also assess your stewardship activities. So make sure something that you did is having the desired effect. And think of creative ways to use the NHSN data, because it can really save you time and a lot of effort. I'm an old enough steward that I have done a lot of paper data collection to try to show the effects of our stewardship program. And now we have the help of these automated risk-adjusted SARs to help answer some of those questions. I've heard from critical access hospitals that sometimes it might, because of your size, it might seem like it's harder, but there are, as you've seen today from 2 colleagues and some of the work that we're doing in our network, these tools are available in critical access hospitals and are really a great way for you to benchmark against, you know, similar facilities that have similar characteristics with the same patient types that you might have, which is fantastic. And we do have those new interactive web-based tools that are available on our DASON website. And I can, I'm happy to answer questions from anyone if you want to email me after this talk. But the other thing, because it is Antibiotic Awareness Week, one other benchmarking thing I do want to highlight is every year during this week, it's like Christmas for stewards. The CDC puts out their annual antibiotic use report. My understanding is, we'll bring Melinda back in for the Q&A, but my understanding is that that report is coming out this week, and we'll get the snapshot of calendar year 2022. And that gives you another way to set a potential SAR goal for your facility, because you can actually see the pooled mean SARs for the different categories. And so you can see how all your colleagues around the country are doing, because maybe we all started up with a goal of 1, and now maybe that's creeping down and we're getting behind if we stay with a goal of 1. But Melinda, do you have any updates on that? I look forward to this every year.
Yes, Libby's talking about our 2022 NHSN AU data report, and it is actually officially posted, and the data in the portal is also been updated. So I can put links to both of those resources in a second. But first I want to thank Libby and Mark and Carrie Ann for providing such highly informative and practical discussion on using their AU data for action. And also, of course, want to thank Amy and providing an overview on the CMS PI and AUR. And I think I'll let Amy answer any questions that she's been monitoring first through the Q&A. And welcome her back. Yes, thank you.
Thanks. Yeah, I think I got them all answered that were related to the PI program reporting, but just a few highlights. So there may be many of you out there that send your isolates out to an external lab for identification and or susceptibility testing. Just because you send it out doesn't necessarily mean you qualify for the exclusion. It more depends on how the data come back to you. So if those data come back to you in discrete fields that your vendor, maybe your EHR vendor, or if you have a third-party infection control vendor, that they can pull the data that we need correctly and completely, then you can submit your AR data and you would not qualify for an exclusion. But if you send the isolates out and those results come back to you, like I mentioned before, in a PDF or a fax or something, a blob of text, if you will, then those are not considered discrete data elements and you would meet the criteria for the exclusion. And then related to that, if you are meeting the criteria for the AR exclusion, technically you're not required by CMS to submit AU data to NHSN, but NHSN would encourage you to submit any AU data you have, as evidenced by today's wonderful panel. There are lots of great things you can be doing with your AU data, even if you're not getting credit for it for the PI program. And then just a last plug, if you think of any other questions you haven't gotten answered today or would like clarification on related to the AUR reporting and PIP program, please email us at nhsn@cdc.gov and we're happy to answer those. So I'll stop there, Melinda, and turn it back over to you. Thanks.
Thank you, Amy. Maybe I'll start off with you. And I know your last bullet here is about the new interactive web-based tool available, but we did get some questions regarding where your tips and tricks will be located. And if you could just maybe once again provide an overview of the project and what is available online for stewards to utilize.
So we have a single launch page. It is on our DASON website. It is under our publications and project section, and it is a quick drop down and you can pull it up there, and then it's all interactive. So it's not a single downloadable item. It goes from page to page. You can click on the clinical case scenarios if that's how you want to interrogate it, or you can go to the metrics guides that are there. The metrics guides are also linked whenever they're used in a clinical scenario, they link out. In the clinical scenarios, when there's an NHSN tips and tricks guide, we actually also link directly to that. So you can go right there from the clinical scenario. We have the metrics guides, as I mentioned, and we have the PowerPoints that are there as well as users guides on how to create them. I will share, they actually are converting our website software today, so I need you to give me just a little bit longer. We had such bad luck. It's a Duke-wide thing. So if you're clicking right now, you might not see it, but I promise come back and it will be there. So all those tools are readily available. And we're excited, developed with the help of a lot of stewards. And today we focus primarily on examples that involve the adult patient populations, but we have something for everyone. We have the neonates are there, we have oncology, we have the pediatric units. They all have examples on how to use the data from real certified pediatric stewards who guided those case reviews to help you. So all patient populations are accounted for and included.
Great, thank you, Libby. We did get another question. I think I'll maybe reframe it a little bit in terms of we talked a lot about the STAR today and using the task reports, and we had a question about using the rates in terms of days of therapy per days present. And Libby or Mark or Carrie-Ann, do you use that at all, unadjusted rate to augment any of your stewardship activities?
We do. I'll go ahead and start and say we sometimes do use unadjusted rates for various reasons, but if you're looking for a good benchmark, there's no one right answer, just like there's no one right answer for what SAR you want for your facility. But in that antibiotic use report, I hope you all understand how excited I get for this to come out every year. There is a companion guide, so you can download from the CDC website the PDF of the full report, but then there's this Excel spreadsheet that actually has lots of drill down data on more specifics that will give you some idea if you're looking for that for a benchmark. But again, there's no one right answer, and we tend to use the rates of data to show changes with time to some of our providers who've gotten used to seeing that sort of data. Or especially if there's an area in the hospital where we do not yet have SAR risk adjustments for, because those facilities do exist. Although we've gotten people so used to the SARs that they get frustrated when they don't have SARs. So we've actually had we've had some units in some of our hospitals get very specific in their classification and they fall out of a SAR category, and they lobby infection prevention to get reclassified so they can go back in and have SARs calculated for their area. So those are I would say that when there is not a SAR available for that facility location type, that is when we most commonly use the rates.
Melinda, we still report DOT. We also report rate days present for some antibiotics. So we're still utilizing that, but along with the SAR for our dashboard.
Great, thank you. We are at the top of the hour, and I once again want to thank our speakers and thank everyone for joining, and wish you a great U.S. Antibiotic Awareness Week and also a National Oral Health Day. Thank you for joining.